professional healthcare to personal home care.
Hi, good afternoon, everyone. And what I want to tell you about is a journey that I think, hopefully many of us will go through at the later stages of our life. And this is the time when we start to lose independence, and we start to need more care, more interventions at home and in hospitals. And the truth is, right, that if you look at the Western world, we can see, right, especially, for example, a lot of the data presented as the talk is based on the United States, is this inversion of the population pyramid, where we had the baby boomers, from 1960, just post-war, with a very much pyramid-like structure, moving towards a more flat structure or a kite structure, as we see in places like Japan, for example, and other places, where we start to see a top-heavy population demographic, which means there are going to be less people to take care, of course, of the older people. And this is something that is, quite clear if you look at young families today, where there are, the average kind of birth rate is 1.2, and it's especially low in Malta. Now, the question that we want to do is, how do we address this issue, now, and trying to prepare for the future? So if you look, and if people have been in Malta, have been looking, at the government's 2050 vision, and these visions that, often get forgotten even before the ink has dried on the paper. But I tried to come up with another 2050 vision for us, and this was my vision. Okay, so to try and increase the people, or reduce the probability by 50% of people dying before the age of 70. So this means, right, that we're trying to move, and this is automatically happening, right, with great healthcare, great intervention, of course, more drugs, more complicated procedures, but to try and look at, increasing the population that are over 70, right, by 50%. This, of course, in my opinion, should also tie in with reducing childhood obesity by 50% that we have in Malta by 2050. Of course, this is going to produce more strain, right, on the healthcare system. And the position that we take, at least, or the work that I look at, is to try and basically reduce this cost of assisted living, right, by leveraging devices that people of our generation, at least the generation that I can see in the audience, right, are familiar with. So standard devices like your mobile phone, wearables, IoT devices, right, that can basically track our aging as we go forward. If you start to look at aging diseases, right? For example, things like Alzheimer's, like Parkinson's, that are now have, tenuous ties to metabolism, to other metabolic pathways and things. The idea is to begin to start collecting data and move from a data-starved situation to a data-rich situation in the tracking of aging diseases. And we see, right, because the cost of assisted living, as you can see on the slide, is increasing almost exponentially between 2022 and 2030. So the idea is to try and leverage mass market mobile devices and mass market sensors to be able to move from reactive medical interventions to proactive and preventative medical interventions. So, for example, one of the things we're working on mostly, is patient falls. Now, the single most predictor of a patient falling is how many falls he's already had. Now, you see that you think that this is a kind of almost trivial thing, but when I came into this space, I discovered a lot more about how elderly people fall. Elderly people don't fall the same way as young people fall. They tend to be more, missing the chair, for example, sliding off the edge of the chair, or, for example, bending forward to tie your shoelaces and your head, your top heavy, kind of rolls you over. But this fall, right, is not only a financial toll on our health services and our healthcare services, it's also a big toll on independence and independent living, because very often the elderly people don't have the strength to stand up again. So what we've been looking for and what we've been looking at is to try and, if you like, put sensors or use sensors that we wear in order to be able to assess and predict the probability of falls, not to the accuracy of us telling you you're going to fall on Tuesday, the 16th of December after your Christmas party because you've drank too much, right? But it's more about giving a risk and saying, listen, you might need carers to come 2 to 3 times a week rather than moving into a care home, and kind of managing the continuum, okay, between, living at home completely independently to living completely in a care home. And of course, the United States are a bit more advanced, at least from my perspective, than what I see in the UK and things. And the Mayo Clinic made a very good study over the past 2 years. I think it started to 2020, where they started to move this hospital at home. Now, the reason why, of course, 2020 and 21 were very important for this, right, was COVID. The health services were completely inundated, and whatever you could farm out to people's homes and residential things was a good time, if you like, to make a study, right? Because you had this natural uptake of people not wanting to go to hospital because it was more likely to contract other diseases. So they set up a system which was a computer tablet where you could have automatic, let us not say automatic, but kind of visits at home online. Personally, a response bracelets. Now, these are already available in Malta. But what they did, right, was kind of try and democratize it and give this to a lot of people. So if you look at the study demographics, right, so there was about over 3,300 patients, right, which saved over the 2 to 3 years when the study was finished, over 17,600 hospital days. But more importantly, right, if you look at is the 15% reduction in readmission rates. So what you're doing is you're alleviating the pressure on the health services, especially the primary health services, where older people go and sit in waiting rooms for a long time. And they had such a good uptake, right, that 94% of the people would recommend it to their friends to take it up. Now, of course, this is in the United States, where getting to the hospital is not nearly as simple as driving 25 minutes down to Mater Dei. So what we looked at, right, is the system that we developed, is it's a suite of sensors and a platform, okay, that can bridge this journey, if you like, between the national healthcare and the home care. So it's basically you giving feedback to your GP, to people, to your family members that can subscribe to your home, to things, to see your activity, whether you're falling over, but even more, let us say mundane or trivial things, that, for example, how often you woke up to go to the toilet, to the bathroom at night, whether you went to the bathroom at night and didn't come back for 45 minutes, or whether you went to the kettle 3 or 4 times, or whether you go back and forth to check whether you've locked the door after you've come in and out. These are all small, let us say, trivial things that can lead, of course, they're not necessarily because you've forgotten, on the pathway to dementia. But what we want to do, at least with the system, is to create a data-rich environment where we can begin to mine these rich data sets of people in their natural environments, not in a hospital, not in a clinic, where they're getting on with their daily lives, and we're beginning to understand how they're aging, not only compared to themselves, but compared to the demographics of people around them, to see whether you are at an accelerated aging rate or a decelerated aging rate, and what interventions you can possibly do at a preventative level to see how you can slow down this aging process, if indeed you can. So this is basically what I said. And what we've developed is a suite of sensors. These have been developed, and now the middle ones are now already available in Amazon. And what we did with this, right, we went for an extremely cheap entry point. So, I think it's $50 for 3. And with no subscription model or fees, because what we wanted is for people to get the buy-in, because what we're really interested in is getting the rich data sets to understand how the people are aging and making people age at home for longer than we can see. So of course we had to produce a software system behind it, and this was trialed out between both in the US, in the Billings Clinic in Montana, and also in Malta, the health service with the Ministry of Active Aging, and also with St. James. Because the reason why we wanted to do this, right, is we wanted to also understand the feedback, not only from the user, which is the aging person at home, but also from the caregivers, understand what is useful for the nurses when an intervention should happen. The last thing you want to do is false alarms, right? This is always the worst thing, and false alarms, are a bit complex in this space. If you have a relatively large dog that falls or jumps from your sofa onto the floor, it's quite easy to confuse that with a person that just falls on the floor. Now, you don't, for any of you who have pets, you really don't want the nurse to call you every time your cat jumps from the sofa or this. So there's a lot of work in understanding and the data sets and retrieving the information from it. So this is what we basically trialed out in an aging home here in Floriana, just a few 100 meters above. And what we can tell, so this sensor, just to give you an idea, is exactly the same sensor as you have in your car. So it's the same sensor that beeps, that measures the distance. But what we can do with some clever algorithms is as your car measures the distance between your car bumper and the obstacle, we can measure the rate at which your chest is moving. So we can infer a breathing rate. From this, we can separate your breathing signal, okay, and measure your heart rate out of this. And further than this, now we're trialing this in UCL, we can actually measure your blood pressure. So the idea is that you can measure these vital signs from a sensor that is under your bed, in the wall, or above the ceiling. So it can do it. So if you're in a ward situation, you can have the sensor in the soffit, and you can measure 2 or 3 sensors at once. We've trialed this also in the automotive world with a client which wanted to look at driver monitoring, sleep, and distractions. So, of course, when you start to have these sensors, you can pick up, of course, other things. So, we can begin to look at, for example, sleep apnea, but even more important things like fits, like episodes of epilepsy and movement, right? Because what the radar does, it picks up this microfine movement, and then there's a lot of work that happens in the classification of movement patterns and acceleration to be able to say whether this person has stopped breathing because he's got a sleep apnea episode, or whether this person, for example, has a fit, or for Parkinson's, whether the shaking has increased more over the past few months or not. More interestingly, right, we're trying to look and see whether these sensors can pick up things that are environmental. For example, like air quality. Is the person coughing more by picking up coughs from the chest? Is the person's asthma medication working? Has the person stopped wheezing? Have we stopped having these deep breaths? So I think the whole thrust of this talk is to try and convince you that the wealth of sensors that there are available now are going to give us very rich data sets between, let us say, 2025 to 2050 to be able to help us to understand how people are aging and to help people spend more quality time at home rather than at the hospital. And I'll just finish here because I think I'm out of time with basically, 2 main things, right? One is, the more people that can stay at home, right, the more quality of life they have, the more time they spend with their family and things. And also, the one big advantage of staying at home, right, is that you're not exposed to many things like MRSA and very strong, antibiotic-resistant superbugs that live, by their very nature in hospitals. Thank you.